Adrenal insufficiency or Addison's disease is primarily then going to be a deficiency of our two priority hormones, the decreased cortisol and the decreased aldosterone. So again, if you first and foremost need to know, is Addison's more or less of the adrenal hormones? And in this case, it's less. I always think you need to add more. That's a good way to remember. So Addison's disease is a deficiency of cortisol and aldosterone. And it's really important to know that first and foremost, so that when we get to the signs and symptoms and the treatments, it all makes sense. So etiologies are listed there. The most common etiology is the therapeutic use of corticosteroids, because if we were to abruptly stop or we don't taper down, our own adrenal gland has basically been on vacation when we are getting synthetic steroids. We're getting the synthetic version, so our body knows that it has enough, so it doesn't have to make any. And so if we stop abruptly or don't taper down, we could go into an adrenal crisis because our body does not have any cortisol. It can't just all of a sudden produce the amount. It needs to have time to remember how to produce and how much to produce. So that fourth bullet there on the etiology is a really important one. So with Addison's disease, we want to focus again on the decreased cortisol and the decreased aldosterone. And with that, we see a lot of our signs and symptoms. So we have less holding on to sodium and water. So there we have our decreased blood pressure, decreased sodium. We will have less holding on to sodium and water, and so we will be looking at an elevated potassium level. So again, think first and foremost, aldosterone holds sodium and water and excretes potassium. So if we're not holding sodium and water and we're not excreting potassium, our potassium is going to be high and our water and blood volume is going to be low. So that's the starting point for all of those cardiovascular signs and symptoms that you're seeing there. Certainly they could have neuromuscular signs and symptoms, muscle weakness, fatigue related to that, and then hypoglycemia as well, because remember we have decreased cortisol. Most all of the Creative Memories notebooks for this endocrine system are awesome. So again, if you like to learn this way, you can use this picture. You can add and put more of your own notes or the rationale for why the signs and symptoms, because again, I feel like if you understand the signs and symptoms and the rationale, then you really kind of know what's going on in the body, and that will probably help you with the treatment as well. So management of Addison's disease will be certainly increasing fluid balance. We'll be doing acrid I&O, daily weights, vitals, orthostatic blood pressures, decreasing stress and managing to prevent an Addisonian crisis, the monitoring of steroid therapy, as we talked about in particular, making sure that they taper off and don't stop taking abruptly, and then all of the education, medical alert bracelet. If they know that they have Addison's disease, they're going to be at risk, especially if they do have an increased stress response, because if they have a low amount of the hormones, they don't have an absolute deficiency of them, but they have a low amount. When they have a stressful situation and their body needs more, then they might not have enough. So that's where we really are going at with all of the medical alert bracelets, having preloaded syringes for emergency situations, and just making sure that people know that they have this so that they can make necessary med adjustments. For example, that last hash there on the plan for med adjustments, targeting stress response, we typically will give patients with known Addison's disease injection of cortisol, solumedrol prior to surgery, for example, to give them an extra bump of synthetic so that they have enough to respond during that stress response that they are expecting. For management of Addison's disease, very important to think about increasing fluid balance. They'll be on an acrid I&O, a daily weight. We'll be checking vital signs and orthostatic blood pressures. Decreasing stress, we want to avoid any extra stress that would in order to avoid an Addisonian crisis. We'll monitor steroid therapy. As I discussed, they'll need to taper off. We don't want them to stop taking it abruptly because their body will need time to adjust and start producing that hormone again once they are not taking the synthetic form of it. And then all of the education really relates to medical alert bracelets and preparing for, if there was an increased stress response, we want to prevent infection and stress, because when we have an infection and stress, we have more need for more of the hormone, in particular more cortisol. So with Addison's disease, they may be fine from lots of time or years, but then when they have a severe stress response, their body isn't then able to produce enough, and that's where they run into the problem with more deficiency that's affecting them. The last bullet talks about planning for mid-adjustment, targeting a stress response, and this has to do with, again, if we know that they're going to have, say, a planned surgery, we know that that surgery is going to result in a stress response and need for more cortisol, so they will give additional IV methylprednisone, which is your Solumedrol, before surgery. So they're giving them that extra synthetic dose that their body's probably not going to be able to make enough of. So all of those things are really important to educate our patients about so that they understand their disease and they understand how to prevent complications. So who is at risk for adrenal crisis? Anybody who's not going to be responding well to the hormone replacement. Again, we talked about if they're undergoing extreme stress, especially without adequate glucocorticoid replacement. If they, again, are on prednisone or they have known Addison's disease and they don't get an extra IV bolus of Solumedrol or methylprednisone prior to surgery, during surgery, they might have a deficiency, and so they would be at risk for an adrenal crisis for that. Again, if we abruptly stop the hormone because, again, the body isn't producing the hormone that we're giving synthetically, of course, if we remove the adrenal gland, we're going to have to prepare for hormone replacement so that they don't have adrenal crisis. This slide is really important in helping to depict what can happen with somebody who has an Addisonian crisis, adrenal crisis, and it's the critical, most serious complications of your Addison's disease. So the biggest thing is you'll see on the left, you'll see cortisol and aldosterone. Again, those are the main two hormones. Androgens, if we have deficiency of androgens, it's not really going to be anything life-threatening. So it's really the deficiency of cortisol or aldosterone that are very life-threatening. So decreased cortisol, if we look at that on the top first, there's going to be decrease in hepatic glucose output. So the liver is not going to be releasing that stored glucose as it normally would, and will result in hypoglycemia. And again, profound hypoglycemia will result in cell death and brain coma, and ultimately could be death. Aldosterone, we have very low or absent mineralocorticoid aldosterone. So we lack the aldosterone that's going to hold on to the sodium in water. So we have sodium and water loss because we don't have the hormone to hold that sodium and water. We're going to have more sodium and water loss, and we will also have retention of the potassium. So we will have hypovolemia and hypotension, but then we will also in that cardiac area have hyperkalemia to be looking at. So there's basically 3 H's that you want to be thinking about with adrenal crisis: hypoglycemia, hypovolemia, and hyperkalemia. So our 3 priorities for emergency care for someone having an adrenal crisis, again, we want to think about the hypoglycemia, the hypovolemia, and the hyperkalemia. So the first one is looking at combating circulatory shock. So it's basically treating the hypovolemia, the hypotension. So the fluid challenge is that they need fluid flushes, 0.9% sodium chloride. They will be could be going into hypovolemic shock. So we will put them in the modified Trendelenburg's position. So the head of the bed is going to be down, their legs are going to be up in the air. Hormone replacement, of course, the treatment of the hypoglycemia. So IV hydrocortisone or Solucortef, which is your glucocorticoid. So again, this could be your methylprednisone or your Solumedrol, but again, it's your replacement of that cortisol. Less important is replacement of the mineralocorticoid, but fludrocortisone or Florinef is the example of the drug that's a mineralocorticoid. And then hyperkalemia management. Again, if we think back to fluid and electrolytes, we think of the ways that we can treat hyperkalemia. In this case, we also have concurrent hypovolemia, so we can't really think, oh, furosemide. I have it on here, but remember they're hypovolemic, so do we really want to give a medication that's going to cause diuresis? So they'll be more likely to use the medications that will temporarily shift potassium into the cell. So your insulin and dextrose and the albuterol neb, that top bullet, those are temporarily shifting potassium into the cell to lower potassium without having to lose potassium in the stool like Kayexalate or potassium in the urine like Lasix. So it'll be more probable that we're looking at the insulin dextrose or albuterol nebulizer. And then also remember during this time with any hyperkalemia, they'll be on a monitor. We'll be watching for those peak T waves or wide QRS complexes. And then IV calcium might be a really important thing because that's going to treat the myocardial irritability and hopefully prevent dysrhythmias. And again, hypoglycemia management, in addition to the hormone replacement of hydrocortisone, they definitely will be giving IV glucose, a dextrose solution, and monitoring blood glucose hourly, in addition to monitoring urine output and blood pressure hourly or more as well. Cushing's syndrome then is an excess of the adrenocorticoid activity, so increased cortisol, increased amount of that glucocorticoid or oversecretion, increased amount of the androgens or the male sex hormone, less frequently a problem with oversecretion of the mineralocorticoids, but certainly that would be an increase in the aldosterone. So between the increase in cortisol, increase in aldosterone, and increase of the androgens, we're going to look to see all of our signs and symptoms that correlate with that. Cushing's syndrome is 5 times more likely in men, and it's usually kind of in that 20 to 40 years of age typically. So again, with Cushing's syndrome, when we look at the etiology, one of the biggest problems or where we're going to assess for Cushing's syndrome is excess use of corticosteroid medication. So side effects of steroids are the same signs and symptoms as somebody with an actual primary disease of Cushing's syndrome. So that's going to be most likely when you're going to see it is thinking about this information on this disorder as it relates to use of steroids. I loved both of these different pictures, so I put them both on there. Again, the better that we can understand the physiology and all of the signs and symptoms of somebody with excess cortisol, the better we understand what it looks like for somebody who's being treated with steroids, because that's going to be the more probable, higher incidence that we're going to see patients that have been on steroids or have to take them chronically for a chronic condition. So again, I can't emphasize enough the signs and symptoms here that are very, very important. There's a nice table in your book. Again, when we see Cushing's syndromes, we think also of side effects of somebody being on steroids, and that's going to be the more likelihood that we're going to assess people for these same signs and symptoms. Learn it by body system. Think about what it might look like if we have excess cortisol. Think about what it looks like if we have excess water-conserving hormone, increased aldosterone, where you see like the weight gain and the hypertension, and again, mainly focusing on the side effects of the cortisol. So the general appearance things that you'll look at is that moon face, that really round face, buffalo hump. They kind of have that hump on the back, posterior back, upper neck area. Truncal obesity, again, very common, and then the weight gain, also because of the cortisol, but then because of the water and sodium retention. Cardiovascular, hypertension, and increased blood pressure and heart rate and fluid volume excess, all of that stuff has to do with the excess of sodium and water retention. Again, we know that steroids and excess cortisol will decrease immunity. It's an immunosuppressant. It helps with immunosuppression, and that's many times the indication for use while they're taking a steroid is immunosuppression and to reduce the inflammatory response. But with that, we need to understand that it's going to decrease immunity, and it's decreasing the inflammatory response, which is maybe good, but also has the side effect of increasing that patient's risk for infection. delayed wound healing, and other problems like that. Musculoskeletal wise, patients will end up with osteoporosis and muscle atrophy, muscle wasting, and especially if they're on it chronically, they're at higher risk for pathological fractures. And then of course they'll have the decreased healing time with their bone fractures as well. One of the biggest things that we always just absolutely need to know if somebody's taking cortisol, taking oral or IV steroids, is that it's going to cause hyperglycemia and increase their blood sugar. So even in a non-diabetic patient on cortisol, they may be on a sliding scale insulin. So this can be very confusing to patients who aren't diabetic why they're taking insulin. It also can be confusing to your diabetic patients who normally don't take insulin and wonder if their diabetes is getting worse. So this is very important that the nurse has the knowledge to teach them about what is actually going on physiologically and that this is a side effect of their medication. Increased cortisol will increase the production of hydrochloric acid, which is why increased risk of gastric and other duodenal ulcers. And then dermatologically, they will get kind of these purple lines or what we look like stretch marks on the abdomen where they have the truncal obesity, and also have very thin skin. They typically have very poor IV access also. And then psychiatric, we do know that some patients that go on steroids, even if they're on short-term steroid for, let's say, an allergic reaction, a very bad rash or something like that, where they have to go on a dose pack of steroid, they could have mood swings, irritability. Patients can actually, develop depression or psychotic features, or even worst case, have suicidal tendencies. Some other pictures that might be helpful. The picture on the right, this is actually a female patient, but you do see the moon face, that round face. You can kind of see that buffalo hump on the back of the neck. I mean, we don't see the whole body picture, but there's a lot of truncal obesity. Really thin, scrawny little legs with that muscle wasting is very typical. They might have more oily skin or acne. In this case, you see facial hair. Those are resulting from that excess production of androgen, or the male sex hormone. Management of Cushing's syndrome, adrenalectomy, they can remove the tumor itself or remove the adrenal gland. Now we have adrenal gland, one on each kidney, so may not need to remove both. If it is actually a cancerous type tumor, then they'll just do the adrenalectomy of the one side. Hypophysectomy, if they're having some problem with the pituitary gland, they can remove the pituitary gland. They can perform radiation to it. So again, with Cushing's syndrome, if it's not managed in other ways, they might actually have to do some radiation or removal of the actual pituitary gland. Most probable is just the change in cortisol or steroid therapy, because this is the most common cause of Cushing's syndrome, or what we know as the most common side effect of steroid therapy would be just to change the dose. So minimal dosing to treat the underlying disease is what we need. So they can dose down. Obviously they'll taper up and they'll taper down also. So when you look at priority nursing care for somebody with Cushing's syndrome, again, we're thinking excess aldosterone, excess cortisol, and excess androgens or male sex hormones. We think of all of those body system signs and symptoms that were on a couple slides prior, and we think, decreased risk for injury. Again, we think of that muscle weakness, the muscle atrophy. We think of that bone osteoporosis that can develop. So preventions of falls that might then therefore prevent fractures. They might also need to be on a calcium and vitamin D supplement. Decreasing risk of infection, super high priority. We know that steroids will cause immunosuppression. So for patients that are undergoing an organ transplant, for example, they're going to be on steroids and are immunosuppressant. But this also can mask signs of infection. So it could actually mask or cover up the signs of infection at their organ transplant site. So it's very tricky. We need to be alert. We need to be aware of those patients that are at highest risk for infection, or that have been on steroids, or that have Cushing's syndrome. Preparing for surgery, I did mention this already, but if they are on prednisone, they will need an extra IV dose prior to surgery because their own body is not producing. So they will need an extra dose of IV methylprednisone, which is Solumedrol. Encourage rest and activity. They'll need that activity rest regimen. We need them to be doing activity to help maintain muscle and all of that, but we also need them to get adequate rest because their immune system is down. Promote skin integrity because they do have thin, fragile skin. They can bruise easily. We can open up their skin and cause skin trauma, easy skin tears, etc. So all of that applies. And then the other piece right behind that is thinking that if I do have a lack of integrity of the skin, and now I do have wounds or ulcers, now I'm immunosuppressed and I can't heal as well, and I have increased risk of infection. So it's all encompassing and all correlates with these side effects. Improved body image, they have weight gain, they have edema, they have more masculinization or facial hair. Those are all things that could definitely impact somebody's body image. Thought process, this has to go with more of the psychiatric side effects of being on steroids or excess cortisol. So it can have labile, mood swings, etc. That can be uncomfortable for the patient and the families, and so we need to kind of work through that. And for some people, they have to come off their steroids because of the severity of their psychiatric symptoms. And so they need to let their doctor know right away so that they can get a decision about what to do about that. And then, of course, risk for unstable blood sugar. We know that somebody on extra cortisol is going to increase their sugar, whether they have diabetes or not, so we need to address it. Primary hyperaldosteronism is just an increase in aldosterone, so it is also known as Conn syndrome. So now we have hypersecretion or increase in production of aldosterone. So again, if we know what aldosterone does, we have an increased sodium and water retention, and we have an increase in excretion of potassium. So increased sodium and water and excretion of potassium. So we want to be thinking about spironolactone. So spironolactone or lactone is a potassium-sparing diuretic because we are excreting and losing potassium. That would be appropriate. Potassium supplements, educate them on foods high in potassium. If we remember back, your bananas, cantaloupe, citrus fruit, honeydew, honey melon, sweet potatoes, tomatoes, prunes, molasses, nuts, some of those things. So again, potassium supplementation or foods high in potassium. Sodium restriction, because they are retaining a lot of sodium in water, we would put them on a sodium restriction. And then finally, possibly they might need an adrenalectomy. Pheochromocytoma. This is where we have an excess or hypersecretion of epinephrine and norepinephrine. So we have increase in the adrenaline hormones that are being released. Most of the time it's because of a tumor in that area. You see the peak incidence. It's equal by gender. Again, we're going to have excess adrenaline hormones, which is your epinephrine and norepinephrine. So we think of the function of those fight or flight hormones, epinephrine, norepinephrine, and we think of vasoconstriction, an excess activation of the sympathetic nervous system, excess amount of vasoconstriction. That's going to be the physiology of pheochromocytoma, and that's going to be related to the signs and symptoms that we'll see next. So the 5 H's, hypertension, again, too much adrenaline and epinephrine, too much vasoconstriction, right? That vasoconstriction is going to produce your hypertension, also could produce elevated heart rate, palpitations, other cardiac dysrhythmias. Patients can come in, 250 over 150. They are in a hypertensive emergency, high risk for stroke and CVA and other complications. So hypertension, headache, as we have more of that, increase in heart rate, increase in blood pressure, and increase of those hormones can produce headache, hyperhidrosis, excessive sweating, again, hypermetabolism, and then hyperglycemia. So those are all the things that we're looking at. And again, we're most significantly worried about that hypertension and fatal effects and or fatal blood clots that can happen as a result of untreated, very, very high hypertension. So management of pheochromocytoma, if we think of the 5 H's, we would want to put them on bed rest right away. We want to decrease the oxygen consumption. We want to promote, less workload on the heart. We also want to put them in a supine position and in hopes that, maybe that might help with some of their blood pressure. Decrease their blood pressure is a high priority. We will be expecting to give the direct vasodilator, so sodium nitroprusside, or the hydralazine, which is the same as a presaline. So those are going to be your direct vasodilators that are going to work the quickest, that we learned about during treatment of a hypertensive emergency or hypertensive crisis. Adrenalectomy is surgical removal of that tumor of the adrenal gland. So the big thing with the adrenalectomy is that they do have to have their blood pressure controlled for approximately 7 to 10 days prior to doing surgery. So we'll need to get that blood pressure managed and under control before they would ever go back and take them to surgery. Nursing care after an adrenalectomy, because we have taken out the adrenal gland, we are needing to think of the impact or the possibility of adrenal insufficiency. So IV steroids would be necessary. We want to monitor for adrenal insufficiency, which is your hypotension, hypoglycemia, and hyperkalemia. Remember those 3 H's for Addisonian crisis or adrenal insufficiency. Educate on steroid therapy, because they will need replacement of that, and that hormone replacement for life. Again, all of the teaching that we would do for somebody that needs to be on chronic steroid. So this is a really good slide talking about, the happy, the good things of corticosteroids, the bad and the ugly. So I think it's really good. Again, there are lots and lots of things that we look at. You also want to remember all those names, all end in O-N-E. So again, methylprednisolone, prednisone, dexamethasone, fluticasone, so you'll start to recognize all of those as our steroids. So you can read through this more. This is a summary slide for corticosteroid therapy. Kind of shows some of our indications for use. So chronic and acute conditions, certainly used for adrenal insufficiency when we lack enough cortisol. But again, you'll see it mostly people need to be on either short-term or long-term for acute inflammation, autoimmune disorders such as lupus, allergic reactions, certainly with an anaphylactic reaction, this would be applicable. Asthma or asthma exacerbations, like the inhalers that are steroids. So again, we see a lot of steroid use for a lot of reasons. There are people that need to be on them, but hopefully we can just be on short-term steroid use, taper up, taper down, and not stay on them forever. So large dose therapy at 8 o'clock, the best time is to take it in the morning. This is when the gland is most active, so this is when we would get maximum suppression of the gland. So we want to give that during the morning hours. Also, we don't want to give it at night, because that is going to not allow us to sleep and will cause insomnias. So I'm not going to read through this again and give the rationale, because I've already went through all of the body systems and the effects for Cushing's syndrome. So this is exactly the same. Side effects of corticosteroids is the very same slide as signs and symptoms or clinical manifestations for Cushing's syndrome. I added this in for those of you who like, remembering via this way. So how to remember the side effects of glucocorticoids. It does have, hit the high points of what are the priorities. And just some review questions. Again, we should be able to understand enough to be able to teach our patients as why they should never miss a dose or not, or suddenly stop taking it. So again, we need to explain to them that while you're taking the replacement therapy, the synthetic, your adrenal gland is basically on vacation. It's like sleeping. It doesn't need to produce anything because the body has it. So as soon as the body doesn't have it, if we stop taking abruptly, then the body isn't going to be able to produce enough quick enough to be able to cover that, and so they could be at risk for adrenal insufficiency if they do stop taking it abruptly. Correct answer here is 1. Correct answer is 3. Correct answer here is 4. 4.